from today we are starting a new topic, that is breast. Okay, so majority of the questions will be asked on carcinoma of the breast because it is the second most common cancer in the world. Okay, so starting with the breast, we need to know about anatomy. So in surgery per se, we need to know about anatomy and pathology. Only then we can decide what the treatment we can do by operating on it. So for that reason, I have taken a bit more extensive pathology of breast, and then related to that, I'll be telling the treatment from the surgery point of view. Okay, so please keep up with me. Yeah, starting with breast normal anatomy. So normal anatomy of breast, you can say, you can divide it as follows. Like, there are two major structures in the breast which can be divided as ducts and lobules. Okay, and there are two types of epithelial cells, mainly luminal cells and myoepithelial cells, and there are two types of stroma, that is interlobular stroma and intralobular stroma. So based on this, this is a normal anatomy of the breast. If you draw a diagram of a breast, so this will be the lactiferous sinus. Okay, I'm just drawing one part of it. Okay, so yeah, so this is a lobule, and within this is a duct, that is intralobular duct, and outside this is the interlobular duct. So this is a lobule. Okay, and if you see a cross section of a duct, it will be lined with two types of epithelial cells. Okay, what are the two types of epithelium? One is luminal epithelium. So this is the luminal epithelium. Within that is the muscle cells called as myoepithelium. Okay, so and it is made up of ducts and lobules. So this is a duct, this is a lobule. Okay, then two types of cells over, and then stroma, that is connective tissue. It can be two types, one being intralobular stroma. So within this stroma, that is intralobular stroma, and between this lobule and this lobule there is connective tissue. This is interlobular stroma. Okay, so if they say lobular carcinoma, you need to know that it is arising from a lobule. For that reason, anatomy is important. Okay, so this consists of normal anatomy of the breast. So there are two major structures, ducts and lobules. After this, there are two types of epithelial cells in the breast, that is luminal and myoepithelial, and two types of stroma, interlobular stroma and intralobular stroma. After this, so this is again a diagram depicting the same. So the histopathological functional, structural and functional unit of breast is called as terminal duct lobular unit. So this is in short known as TDLU. What is TDLU per se? Andre, it is a terminal duct along with lobule. So just like I have said, this is a lobule and this is a duct. So this consists of TDLU, terminal duct lobular unit. Okay, so ಇದರಲ್ಲಿ ಎರಡು ಇನ್ಕ್ಲೂಡ್ ಮಾಡಿದ್ದೀನಿ, one lobule ಅಷ್ಟೇ. So this lobule plus duct ಅಂದರೆ lobule plus terminal duct. This is the structural and functional part of breast. Okay, histologically also. So knowing this is very important because from this is the site where everything starts, where every carcinoma starts. Okay, so after this, yeah, so this is again in detail about the anatomy. So this is a lobule, and whatever the stroma there in between the two lobules is interlobular stroma. Within this lobule is the intralobular stroma. Okay, and then this one duct is called terminal duct. Okay, after this, this is a ductule and this is a duct. So all these small ducts whichever arises from one TDLU will join one major duct, and that will in turn form a big duct called as lactiferous sinus, and it will open through the nipple. Okay, so this is the anatomy. Yeah, just like I have told before, the duct is lined by two types of cells, that is lining one is myoepithelial cell and the other one being luminal cell, and it is covered, both of these cells are covered by a basement membrane. Okay, this whole pathology, I mean this whole structure in turn is called as ductule or acinus. Okay, yeah. So coming to pathology of breast per se, what are the common lesions we can see in case of a breast? Okay, this we will divide it into two types, basically epithelial lesions and stromal lesions, because there are two things. One is the epithelial lining, other one is the connective tissue. Based on that, epithelial, again it can be divided as benign lesions or malignant lesions. Okay, so again benign lesions can be divided as proliferative or non-proliferative, proliferative or non-proliferative. Again, this proliferative can be divided as proliferative lesions without atypia or proliferative lesions with atypia. Similarly, non-proliferative diseases or non-proliferative lesions mainly include fibrocystic changes and lactational adenoma, which we will discuss. Okay, so this is the main classification. Again, in the epithelium, malignant lesions, they can be in situ or invasive. So stromal lesions, it can be a fibroadenoma or a phylloid tumor. So this basically gives you the entire thing which we will discuss in today's class. Okay, so what are the common lesions of breast? Epithelial and stromal. So how epithelial is divided, how stromal is divided, so that we are discussing now. Starting with epithelial benign lesions which are proliferative and without atypia. So this is epithelial benign proliferative without atypia. Okay, so this consists of epithelial hyperplasia, sclerosing adenosis and papilloma. So these are the conditions which are epithelial and benign, and they are without atypia. So similarly, examples for benign proliferative lesions with atypia are atypical ductal or lobular hyperplasia. Okay, so we will deal with this individually. So starting here, we are starting here. Okay, yeah. So this is a benign proliferative disease without atypia, which has an increased risk of developing breast cancer. Hence, we need to know about this disease, because if we diagnose the disease in this case, we know that this will progress into breast cancer, and so by treating this, we can reduce the chances of, or reduce the incidence of breast cancer. For that reason, we need to know about all these conditions. Okay, these are often detected as mammographic densities or calcifications. Suppose we have performed mammography on a patient and we have noticed some certain densities or calcifications on mammogram, then we can diagnose it as proliferative breast disease, and based on that, again we can classify based on histopathology. So according to that, we can treat the condition. Okay, so this is considered as predictors of development of breast carcinoma, hence we need to know about this. So yeah, proliferative breast disease without atypia, just like I have mentioned before, examples were epithelial hyperplasia. In this, okay, without atypia, there is a chance that 5 to 7% of these conditions might develop as breast cancer. So in that, first one being epithelial hyperplasia. Epithelial hyperplasia andre enagutte, we know epithelium consists of two types of cells, that is myoepithelial cell and luminal cell. There is hyperplasia of these two types of cells. Hyperplasia andre ಏನು, increase in cell number ಅಷ್ಟೇ, size ಏನು ಆಗಲ್ಲ, ಬೇರೆ ಏನು ಚೇಂಜ್ ಆಗಲ್ಲ, just there is increase in number of this myoepithelial and luminal cells. So that if we diagnose it, like suppose we have done a mammography, we noted density and calcification on mammography, so we took a biopsy of that specimen and we are visualizing it under microscope. At that condition, if we were able to see that the luminal and myoepithelial cells of the ductules are more in number, then it is diagnosed as epithelial hyperplasia, and we can predict that okay, this patient 5 to 7% there is a risk of developing invasive cancer. So we will monitor her closely, we will tell her to come for regular checkups, so and so. Okay, we can just advise the patient that you are at risk. Okay, similarly, sclerosing adenosis. So just like the name suggests, sclerosing and adenosis. Adenosis means, adena means gland, so there is increase in number of glands or acini in a lobule. Okay, hence in this adenosis, there is distortion in the center and extensive stromal fibrosis will occur. So this is called as sclerosing adenosis. There is increased number of glands in a lobule. Okay, along with that there is sclerosis. So because of that reason, it is called as sclerosing adenosis. If this is noted again, there is a 5 to 7% risk. Papilloma, these are growth within the duct which will dilate the duct. Okay, so it's like if this is a duct, there is papilla like growth here. So this what, because of this the duct will dilate like this. So these are the growths which dilate the duct and they are finger like projections with multiple fibrovascular core. If this is a papilloma, there will be a blood vessel through this and this is called as vessel. So fibrovascular core, this will be a papilla. So these kind of growths will occur within the ducts and that is called as papilloma. Okay, so this can happen within the small duct or within the large duct. So small duct like lobules, intralobular duct. In that, if there is a papilloma on mammography, we will be able to see calcification. Okay, if it happens in large duct like lactiferous sinus, then usually there will be associated clinical manifestations like bloody or serous discharge from that nipple, and on that basis we can say okay, there might be a papilloma. Okay, the fourth condition of proliferative breast lesion without atypia is complex sclerosing lesion. Complex sclerosing lesion is nothing but a mixture of what we studied in the above three. That is, it can be like epithelial hyperplasia, it can be like a sclerosing adenosis, or it can be like a papilloma or mixture of all these three. So it contains all the components like sclerosing adenoma, papilloma and epithelial hyperplasia along with a radial scar. So this closely mimics invasive carcinoma and hence we need to differentiate this very cleanly so that we don't confuse it as actual carcinoma. So this is a pre-malignant condition and it is not exactly carcinoma. So hence for this reason it becomes very important to differentiate complex sclerosing lesion with actual invasive carcinoma. And the fifth condition, that is benign proliferative breast disease in case of males. This is the only condition where males can develop into invasive carcinoma, that is gynecomastia. So this is a condition where males have enlarged breast. Because does this happen in males? Because of imbalance between the estrogen and androgen. So in males, androgen should be more and estrogen should be less. If there occurs an imbalance where estrogen becomes more than androgen, then this condition leads to development of gynecomastia, that is enlargement of male breast. So why, if there is increase in estrogen, there should be gynecomastia? Because estrogen is the one which stimulates the growth of the breast tissue. Because of that reason, there will be gynecomastia. So most commonly this will be seen, that is gynecomastia is seen in case of elderly males because of relative increase in estrogen as they age, and certain drugs like alcohol, marijuana, heroin and antiretroviral therapy and steroids are also known to cause gynecomastia. Other than this, Leydig cells tumors or Sertoli cells tumor, because they secrete hormone. These are hormone secreting tumors and they might secrete estrogen, which in turn lead to gynecomastia. Other conditions like Klinefelter syndrome or liver cirrhosis can lead to increased estrogen and thereby, or increased androstenedione, which will convert into estrogen and thereby causing gynecomastia. So this was about gynecomastia. So now we have dealt with 5 main diseases, which are proliferative breast disease without atypia. Okay, so just a quick revision. First one we discussed about epithelial hyperplasia. Second one we discussed about, here discuss the second one, sclerosing adenosis. Third one is papilloma, which can be small duct papilloma or large duct papilloma. Then complex sclerosing adenosis, which is a mixture of all these above three things. And fifth one being gynecomastia. Okay, so these were the proliferative breast diseases without atypia. Now coming to proliferative breast diseases with atypia. I am taking it nice and slow so that all of you get the basics right and then we can hurry it up. Okay, so yeah, starting with proliferative breast diseases with atypia. Okay, so this has more risk of developing into invasive carcinoma, that is 13 to 17% risk more than proliferative breast disease without atypia. So under this there are two conditions. One is atypical ductal hyperplasia. So atypical ಅಂತ ಯಾಕೆ ಕರಿತೀವಿ ಅಂದರೆ there is no specific pattern, ಹೆಂಗೆಂಗೋ ಇರುತ್ತೆ. For that reason it is called as atypical. Okay. So atypical ductal hyperplasia ಅಲ್ಲಿ ಏನಾಗುತ್ತೆ, there will be ductal hyperplasia, that is monomorphic proliferation of regularly spaced cells in the ducts. So this is monomorphic, ಒಂದೇ ಥರ ಇರುತ್ತೆ. Okay. Like this cribriform spaces. So actual duct ಹೆಂಗಿರಬೇಕು, ಸುತ್ತ ಸೆಲ್ಸ್ ಇರಬೇಕು, ಮಧ್ಯದಲ್ಲಿ ಓಪನಿಂಗ್ ಇರಬೇಕು. ಬಟ್ ಹಿಯರ್ ವಾಟ್ ಹ್ಯಾಸ್ ಹ್ಯಾಪನ್ಡ್, there is proliferation of the cells in between the duct also, which is creating many spaces inside one duct. So this partially fills the duct, okay, because of hyperplasia, increase in number. And then there is mild atypia, that is cells can be a little bit different, like monomorphic irutte, but again atypia will be there. So in a second condition being, this was about atypical ductal hyperplasia, and then other one being atypical lobular hyperplasia, in which uniform population of cells with oval or round nuclei with small nuclei, they will undergo hyperplasia, and this do not form lumen or papillary projections, and the acini are not distended, which is more than 50%. Okay, so ಇಲ್ಲಿ ಏನಾಗುತ್ತೆ, basically whatever the anatomy we had discussed alla, like in our TDL, what all are there. So basically this is a lobule, this is a duct. So atypical lobular hyperplasia, atypical ductal hyperplasia, these are the proliferative diseases, breast diseases with atypia. So this is a duct. If there is atypical ductal hyperplasia, that is atypical, ಇಲ್ಲಿ hyperplasia ಆದರೆ atypical ductal hyperplasia ಆಗುತ್ತೆ. If there is hyperplasia here, then that will become atypical lobular hyperplasia. Both these have a risk of about 13 to 17% to become into invasive breast cancer. Okay, so this was about proliferative breast diseases. After this, per se, we had to discuss about other causes like non-proliferative. ಇದು fibrocystic changes ಇರುತ್ತೆ, like and lactational adenoma. Okay, so these all are not much important. Like if we go on discussing this, it will become a pathology more than a surgery class, so I am skipping all this. Okay, so non-proliferative andrenu, these are not much harmful. Okay, these are like lactational adenoma andre ivaga in a breastfeeding woman there will just be formation of lump like thing, which is normal physiology. It will regress on its own, no treatment is needed. Such conditions I am omitting. Okay, now the next one we are going is malignant conditions, that is in situ carcinoma and invasive carcinoma. At last we will be covering this stromal conditions also, like fibroadenoma and phylloids tumor. Okay, so idondana ನಾನು skip ಮಾಡಿದ್ದೀನಿ because it is of not much significant importance. Now coming to proliferative breast diseases, malignant one, in that carcinoma of the breast. So we just like I told you in the beginning of the class, it is the second most common malignant cancer, and the risk factors being, what are the risk factors, which female will develop carcinoma of breast ಅಂತ ಕೇಳ್ತಾ ಹೋದರೆ we can list so many causes. First one being being a female itself is a risk factor for developing carcinoma of breast, and as the age increases there is an increasing risk of developing breast cancer. Okay, and lifetime exposure to estrogen will decide if the female will develop breast cancer or not. So lifetime increase to estrogen will depend upon if she has had early menarche. Early menarche ಅಂದರೆ ಇವಾಗ 12 years to normally 12 to 45 years is a reproductive period ಅಂತ ಅನ್ಕೊಳ್ಳೋಣ. If she has attained puberty at 8 years of age, then there is increased more 4 years. So for increased 4 years she will be exposed to estrogen. Because of that reason there is a risk of developing carcinoma of breast. Other than that, late menopause. So suppose she has attained puberty at 12 years but she hasn't attained menopause till 50 years. So again there is an increase of 5 years. So because of this 5-year increase there will be increased estrogen exposure. Because of that again she can develop carcinoma of the breast. And then if she has taken hormone replacement therapy, or if she is nulliparous, because in pregnancy there is 9 months of gap where this estrogen will be suppressed, progesterone will be more. Again it is like just like a gap for ovulation and all, there will be less chances of development of breast cancer. So if she is nulliparous, she hasn't had that gap, she has been ovulating continuously, she has been menstruating continuously, For that reason, there will be increased exposure to estrogen, again leading to increased chances of developing breast cancer. And next one being genetic inheritance. So if there is a close family relative who has developed breast cancer, then there is a high chance that she will also develop breast cancer. That is primary, first degree relative, mother, sister, anyone. Okay, like this. So and then there are certain environmental factors which influence the development of breast cancer, like organochlorines or plastics or radiation exposure. These all can lead to development of CA breast. Okay, and there is lifestyle, like high alcohol or obesity. All these will influence, and then these will lead to formation of risk factors. Similarly, just like there are risk factors which can increase the risk of developing CA breast, there are certain factors that decrease the risk of developing CA breast, which are early pregnancy, prolonged breastfeeding, weight control, avoidance of prolonged use of hormones, like hormone replacement therapy la avoid ಮಾಡಬೇಕು, and reduced alcohol and reduced tobacco content or reduced radiation exposure. So all these conditions will ಡಿಕ್ರೀಸ್ ದ ಚಾನ್ಸ್ ಆಫ್ ರೆಡ್ಯೂಸಿಂಗ್ ರಿಸ್ಕ್ ಫ್ಯಾಕ್ಟರ್. ಅದಕ್ಕೆ ಬ್ರೆಸ್ಟ್ ಫೀಡಿಂಗ್ ಪ್ರೊಲಾಂಗ್ ಆಗಿ ಮಾಡಿ ಅಂತ ಹೇಳ್ತೀವಿ. ಎಕ್ಸಸೈಸ್ ರೆಗ್ಯುಲರ್ಲಿ, ಅವಾಯ್ಡ್ ಅನ್ನೆಸೆಸರಿ ಹಾರ್ಮೋನಲ್ ರಿಪ್ಲೇಸ್ಮೆಂಟ್ ಥೆರಪೀಸ್, ಅವಾಯ್ಡ್ ಆಲ್ ದೀಸ್ recreational drugs like alcohol and tobacco. All these conditions will in turn lead to decrease in breast cancer. And early pregnancy is also a decreasing factor for developing CA breast. Okay, so all the breast cancers can be separated into three major groups, which can be defined by expression of two proteins, that is ER, estrogen receptor, and HER, okay, HER2. So these two receptors, based on the expression of these two receptors, we can classify breast cancers into three main types, that is luminal cancer. If there is expression of ER2, that is ER is positive and HER2 is negative, then those kind of cancers are called as luminal cancers. HER2 cancers anta yaake karteve, because ER may or may not be there, but HER2 overexpression will be there. So HER2 overexpression with or without ER expression is called as HER2 cancers. And if the ER is also not there, then HER2 is also not there, then we will check for one more protein called progesterone or PR. And if this is also not there, then they are called as all three are negative, so triple negative cancers, and these are most dangerous, most poor prognosis. Okay, so luminal cancer andre ಏನು ಅನ್ಕೋತಾಯಿತು, HER2 andre ಏನು ಅನ್ಕೋತಾಯಿತು, triple negative andre ಏನು ಅನ್ಕೋತಾಯಿತು. Based on the molecular basis of classification, we can say it has luminal cancers, HER2 cancers, and triple negative cancers. So what is the major difference? What will we know if based on the classification? So if it is a luminal cancer, usually they will peak in late age group, whereas HER2 new cancer or HER2 cancers and triple negative cancers will peak in the middle age group. Late age group andre around 50 to 60 anta ankoona. So this will be around 30 to 40 years. So based on this, we can easily diagnose this. If we know that HER2 cancer and triple negative cancer will be peaking in middle age and luminal cancer will peak in late age, based on this we can diagnose the conditions. So luminal cancer is again classified as two types, that is type A, in which there is low proliferation of cells, whereas type B, there is high proliferation of cells. Okay, then HER2 cancers, there is overexpression of HER2 receptor, hence the name HER2 cancer. HER2 gene amplification will be there, and these will usually respond to drugs which are HER2 new inhibitors. Okay, whereas triple negative cancers, these are associated with defects in genomic repair. Okay, so now coming to pathogenesis of breast cancer per se. So just like we have discussed before, there are various factors like genetic factors ide, hormonal factors ide, environmental factors ide in risk factors. So all these risk factors in turn will lead to pathogenesis in case of breast cancers. So similarly, dividing it again, genetic basis for pathogenesis. So the mutation in BRCA1 or BRCA2 gene, this is function in repair of double-stranded DNA breaks. These two genes ಏನು ಕೆಲಸ ಮಾಡ್ತಿರುತ್ತೆ ಅಂದರೆ, ಇವಾಗ ಹ್ಯೂಮನ್ಸಲ್ಲಿ ಏನಂದರೆ ಡಬಲ್ ಸ್ಟ್ಯಾಂಡರ್ಡ್ DNA ಇದೆ. ಇಫ್ ದೇರ್ ಈಸ್ ಬ್ರೇಕ್ ಇನ್ ದಿಸ್ ಡಬಲ್ ಸ್ಟ್ಯಾಂಡರ್ಡ್ DNA, okay, then this BRCA1 and BRCA2 will function in repairing this gene. So if there is a mutation in this gene, ಅವಾಗ ಏನಾಗುತ್ತೆ, ಈ ಥರ ಬ್ರೇಕ್ ಆದರೆ there won't be gene to repair this, so double stranded DNA will not be repaired, and hence this will lead to cancers. That is why in case of BRCA1 and BRCA2 mutation, there will be development of CA breast, that is breast cancer. Okay. Then coming to TP53, which is nothing but a guardian of genome. So this is basically like looking after every genome in our body. If there is a mutation in this, again this will not check if everything is going on smoothly or not. So genes will not function properly, and again it will lead to cancers. Similarly, P10 gene, this is again same cause. Okay, ಅದೇ ಥರ negative regulator of PI3K AKT pathway. This is again will go into pathology. So just remember, P10 gene mutation adre, again there will be CA breast. Okay, HER2, this we have studied also, HER2 cancer. So this HER2 is a gene which will promote cell proliferation and opposes apoptosis. Andre cell ಸಾಯದೆ ಬದುಕಕ್ಕೆ this will be helping. So if this is over expressed, ಅಂದರೆ ತುಂಬ ಜಾಸ್ತಿ ಕೆಲಸ ಮಾಡೋಕ್ಕೆ ಶುರು ಮಾಡಿದ್ರೆ ಏನಾಗುತ್ತೆ, ಸೆಲ್ಸ್ ವೋಂಟ್ ಡೈ ಓನ್ಲಿ. ಇಫ್ ಸೆಲ್ಸ್ ವೋಂಟ್ ಡೈ, ದೇ ವಿಲ್ ಬಿಕಮ್ ಕ್ಯಾನ್ಸರಸ್. ಸೊ ನ್ಯೂ ಸೆಲ್ಸು ಬರ್ತಾ ಇರುತ್ತೆ, ಅದ್ರ ಜೊತೆಗೆ ಓಲ್ಡ್ ಸೆಲ್ಸ್ ಸಾಯ್ತಾ ಇರಲ್ಲ. ದಟ್ ವಿಲ್ ಲೀಡ್ ಟು ಪಾಪ್ಯುಲೇಷನ್ ಓವರ್ ಎಕ್ಸ್ಪ್ಲೋಷನ್ ಥರ. ಓಕೆ, ಸೊ ಬಿಕಾಸ್ ಆಫ್ ಓವರ್ ಎಕ್ಸ್ಪ್ರೆಷನ್ ಆಫ್ ದಿಸ್ HER2 gene, there will be cancer. Okay, what are the hormonal factors and how does it lead to pathogeny of breast cancer? So hormonal factors, main culprit is estrogen, because estrogen stimulates the production of growth factors like TGF alpha and PDGF, platelet derived growth factor, and tumor growth factor alpha. Okay, this will in turn lead to increase in the cell number, so which in turn will cause cancers. So this is a precursor lesion for cancer, and breast epithelial cells will increase during puberty, pregnancy and cycles. This is normal. Okay, sporadic changes ಏನಾಗುತ್ತೆ, because of estrogen there will be ER plus, hence in case it is known as luminal type, where ER positive is there. Okay, what are the environmental factors? Environmental factors, most of them will influence, like geography ಹೆಂಗೆ ಅಂದರೆ ವೆಸ್ಟ್ ಆ್ಯಂಡ್ ಇಂಡಿಯನ್ ಪಾಪ್ಯುಲೇಷನ್ ಅಂತ ತಗೊಳ್ಳಿ. The population of west have more risk for developing CA breast than Indian population, than Africans have least ಆ ಥರ. So that is how geography will. So if a person is born in the west, he has more risk for developing CA breast. So similarly, radiation exposure and lifestyle ಹೆಂಗೆ, obesity, hormonal replacement therapy, all this, exercise, lack of exercise, late pregnancy and all. Okay, radiation again, this depends on individual. So again it is an environmental factor. So these are the pathogenesis of breast cancer. So till now we have discussed what is like carcinoma of the breast, risk factors ಏನು and protective factors ಏನು, and molecular basis of molecular classification of breast cancers, and then pathogenesis of breast cancers. Now okay, we should know certain differences between BRCA1 and BRCA2. So this, because this almost constitutes of about 80 to 90% of breast cancers. So in case of BRCA1, there is increased risk of ovarian cancer also, and it is usually seen in case of females, and these cancers are poorly differentiated and they fall in triple negative breast cancers. Hence these are most dangerous. Okay, females first, so BRCA1 in females. Similarly, BRCA2, in this case, in this gene mutation, there is increased risk of ovarian cancer, and it is usually seen in males and poorly differentiated. Again, these fall in ER positive breast cancer, that is luminal cancer. So males will usually have luminal type of cancer, whereas females will have triple negative type of cancers. Okay, after this, coming to pathological classification of breast carcinoma, that is, it can be divided as non-invasive or invasive based on how dangerous it is. So non-invasive cancers can be classified again into ductal carcinoma in situ and lobular carcinoma in situ. So non-invasive or in situ ಅಂತ ಅನ್ಕೊಳ್ಳೋಣ. In situ ಅಂದ್ರೆ ಏನು, basically I have told you, like this is a duct, there is a myoepithelial cells, after that there are luminal cells. Surrounding this was the main thing, that is basement membrane, which I am drawing now in black. So basement membrane. So whatever the cancer is there, it will be within this duct. It is not breaking this basement membrane. In that condition, it is called as carcinoma in situ. Okay, if it breaks this, then it becomes invasive carcinoma. It can spread to wherever it wants. So similarly, within this duct, again it can be a ductal carcinoma in situ or lobular carcinoma. So this structure or this diagram becomes most important. Yeah, so this is again duct. If the carcinoma arises from here, that is ductal carcinoma in situ. in situ because it is not breaking the basement membrane. If the carcinoma arises from here, it is lobular carcinoma in situ because this is lobule. So this is ductal carcinoma in situ and this is lobular carcinoma in situ. So this is a transverse section. If you see in cross section, again it depends if we have taken the cross section here or here. Based on that, you can draw the appropriate diagram. So these are the two in situ or non-invasive breast cancers. So invasive breast cancers include invasive ductal carcinoma, and there are other conditions like invasive lobular carcinoma, invasive carcinoma with medullary features, mucinous carcinoma, tubular carcinoma, and there are multiple other types as acinar carcinoma itara, but most common being invasive ductal carcinoma and invasive lobular carcinoma. This will cover about 95 to 97%. Okay, so yeah, again duct lobule iveredu gottidre we can aramse write ductal carcinoma in situ, lobular carcinoma in situ, invasive ductal carcinoma, invasive lobular carcinoma. Okay, so now we'll go in detail with this. So in this case, in situ, cancer cells are confined to ducts and lobules by a basement membrane and they won't break the basement membrane, hence it is called as in situ. There is one more condition, that is Paget's disease of nipple, which is classified under in situ carcinoma. Okay, we will discuss about this a bit later. So just remember, under non-invasive carcinoma there are three conditions, one being ductal carcinoma in situ, lobular carcinoma in situ, and other one is Paget's disease of nipple. Okay, so now coming to ductal carcinoma in situ per se. So what happens here in ductal carcinoma? There is a clonal proliferation of epithelial cells which are limited to ducts and lobules, okay, by the basement membrane, and here myoepithelial cells are preserved but may decrease in number. So illénaಗಿದೆ, hyperplasia ತರ ಎರಡು cells increase ಆಗ್ತಾ ಇಲ್ಲ, here only epithelial cells are increasing. Okay, so because of this reason there can be reduced number of myoepithelial cells or they can be same as before, but other cell which was the luminal cell, these are increasing in number, and but basement membrane is preserved. Okay, that is ductal carcinoma in situ. So this can spread throughout the ductal system and produce extensive lesions. Basement membrane break ಆಗ್ತಿಲ್ಲ, ಬಟ್ ಎಂಟೈರ್ ಡಕ್ಟ್ ಲಾಬ್ಯೂಲ್ ಎಲ್ಲ ಕಡೆಗೂ ಸ್ಪ್ರೆಡ್ ಆಗ್ಬೋದು. ಓಕೆ, ಸೊ ಡಕ್ಟಲ್ ಅರೈಸ್ ಆಗ್ತಿರೋದ್ರಿಂದ ಡಕ್ಟಲ್ ಕಾರ್ಸಿನೋಮಾ ಅಂತಿದ್ದಾರೆ ಅಷ್ಟೇ. This doesn't mean that it will stay limited to duct only. It will start in the duct and it can spread to lobules also. Okay, so what will be the clinical features in case of ductal carcinoma in situ? They can be asymptomatic most of the times, but there can be a vaguely palpable mass and there can be nipple discharge if it involves larger ducts like lactiferous sinus. ಆ ಕೇಸಲ್ಲಿ ನಿಪ್ಪಲ್ ಡಿಸ್ಚಾರ್ಜ್ ಬರೋಕ್ಕೆ ಸಾಧ್ಯತೆ ಇರುತ್ತೆ. ಯೂಶಲಿ ದೇ ವಿಲ್ ಬಿ ಡಯಾಗ್ನೋಸ್ ಇನ್ಸಿಡೆಂಟಲಿ, ಆಯಿತಾ. And on mammography there can be increased density or casting type of calcification or rarely a mass like lesion. Okay, so clinical features mainly asymptomatic or there can be a nipple discharge or vaguely palpable mass. So diagnosis hang ಮಾಡ್ತೀವಿ, usually for some reason we will order mammography and on that we will see all these three findings, and because of that reason it is called as incidental finding. So there are various types of ductal carcinoma in situ again. One being comedoductal carcinoma in situ, in which tumor cells will be pleomorphic, ಅಂದರೆ ಒಂದೇ ಥರ ಇರಲ್ಲ, ಒಂದು ಸೆಲ್ ಒಂಥರ ಇರುತ್ತೆ, ಇನ್ನೊಂದು ಸೆಲ್ ಇನ್ನೊಂದು ಥರ ಇರುತ್ತೆ, and there will be high grade nucleoli. And in this comedoductal carcinoma in situ there will be areas of central necrosis also. Okay, so again this comedoductal carcinoma in situ or ductal carcinoma in situ per se can be divided as solid or mixed. We'll see that. Okay, so first one is comedo type of ductal carcinoma in situ. Second one is cribriform type of ductal carcinoma in situ, which is rounded shape, cookie cutter anta karibodhu idana, often filled with calcified secretory material. Okay, again this is all about extensive pathology, just remember the types. Okay, cribriform ductal carcinoma in situ. There is one more type called micropapillary, in which there are complex bulbous protrusions and there is no fibrovascular core like papillary. Okay, but in papillary there is fibrovascular core and lack of myoepithelial cell layer is there. Okay, so these are the four types of ductal carcinoma in situ. Next, so how do we treat ductal carcinoma in situ? So suppose we diagnose ductal carcinoma in situ based on the mammography or incidentally, we will say the patient to undergo mastectomy, that is removal of breast, which is curative. if at this stage only the patient undergoes mastectomy, then almost it can be cured. Okay, but there can be a chance of recurrence, and we have to explain it. If that there is a high chance of recurrence in case if the high nuclear grade tumor was there, and there was necrosis, and based on the extent of the disease and post surgical positive surgical margins. So if we were able to uh, excise entire tumor, then there will be reduced risk. If even after excision of the tumor there are positive surgical margins, then there is a high chance of recurrence. Similarly, in order to prevent recurrence, we will have to give the patient post-op radiotherapy and tamoxifen therapy, that is hormonal therapy. ಆಯಿತಾ. ಪ್ರೋಗ್ನೋಸಿಸ್ ಏನು, ಲೋ ಗ್ರೇಡ್ ಟ್ಯೂಮರ್ ಆದರೆ, ಲೋ ಗ್ರೇಡ್ ಡಕ್ಟಲ್ ಕಾರ್ಸಿನೋಮಾ ಇನ್ಸಿಟು ಆದರೆ 1% ಪ್ರೋಗ್ರೆಷನ್ ಟು ಇನ್ವೇಸಿವ್ ಕಾರ್ಸಿನೋಮಾ, ಹೈ ಗ್ರೇಡ್ ಆದರೆ ಹೈಯರ್ ರಿಸ್ಕ್ ಆಫ್ ಪ್ರೋಗ್ರೆಷನ್ ಟು ಇನ್ವೇಸಿವ್ ಕಾರ್ಸಿನೋಮಾ. ಓಕೆ, so then coming to Paget's disease of nipple, which is one more type of non-invasive or carcinoma in situ. Okay, this is named after Sir James Paget anta. So this is a rare manifestation of breast cancer. It usually presents with unilateral erythematous eruption with a scale crust with pruritus. So ಇಲ್ಲ ಕ್ಲಿನಿಕಲ್ ಫೀಚರ್ಸ್ ಎಲ್ಲ ಸಿಕ್ಬಿಡ್ತು. ಒಂದೇ ಸೈಡ್ ಇರುತ್ತೆ, ರೆಡ್ಡಿಶ್ ಇರುತ್ತೆ, and then scale like crust ಇರುತ್ತೆ ಮತ್ತು itching ಇರುತ್ತೆ. ಆಯಿತಾ. ಸೊ ದೀಸ್ ಆರ್ ದ ಕ್ಲಿನಿಕಲ್ ಫೀಚರ್ಸ್ ವಿತ್ ವಿಚ್ ಪೇಷಂಟ್ ವಿಲ್ ಕಮ್. In the one side of the breast, patient will say, okay, my one side of the breast has become red, and if I try to remove it, I'll get skin like things, and it is associated with severe itching. So because of this, we might think, okay, this might be an eczema, but it is usually a Paget's disease of nipple. So what exactly happens in Paget's disease andre, there is usually an underlying ductal carcinoma in situ or an invasive carcinoma in situ, and because of this reason, tumor cells from the duct or lobules will migrate to surface of the nipple. Okay, so it's like duct allo athwa lobule allo arise agide, ಆ cells migrate ಆಗಿ ನಿಪ್ಪಲ್ಲಿ ಬರ್ತಾ ಇದೆ. So because of this, and they are not breaching basement membrane, and hence it is classified under carcinoma in situ. Okay, so without breaching the basement membrane, the cells are migrating from the tumor to this, and because of this, there is normal disruption of the normal epithelial barrier, which allows the epithelial cells to seep into the epithelial surface, and because of this, there is formation of crusting. Okay, so clinical features ಏನಿರುತ್ತೆ, crusts and scaly like lesions on the nipple and palpable mass below the nipple, which is nothing but invasive or ductal carcinoma in situ. Okay, so diagnosis ಹೆಂಗೆ ಮಾಡ್ತೀವಿ, whatever the crust like thing we are getting, we scrape that and we visualize it, or we can take a biopsy of the mass which is palpable. So again, biopsy ಬಂದಾದ್ಮೇಲೆ, if it is a ductal carcinoma in situ, we will do the treatment just like ductal carcinoma in situ, nothing but mastectomy. Invasive carcinoma ಏನಾದರೂ ಆದರೆ ಅದು we will study in detail next, ಆ ಥರ ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡಬೇಕಾಗುತ್ತೆ. Okay, so this was about Paget's disease of nipple. So next, other carcinoma in situ being lobular carcinoma in situ. Again, ಇದರಲ್ಲಿ ಏನಾಗುತ್ತೆ, clonal proliferation of epithelial cells limited to ducts and lobules. ಅಗೇನ್ ಇದರಲ್ಲೂ ಸೇಮ್, ಬಟ್ ಏನಾದ್ರು ಫಸ್ಟ್ ಅರೈಸ್ ಆಗೋದು ಲಾಬ್ಯೂಲ್ಸ್ ಅಲ್ಲಿ ಬಂದಿರುತ್ತೆ, ಆಮೇಲೆ ಡಕ್ ಸಿಕ್ಬೇಕಾದ್ರೆ ಸ್ಪ್ರೆಡ್ ಆಗಿರ್ಬೋದು. ಆ್ಯಂಡ್ ಯೂಶಲಿ ದೀಸ್ ಆರ್ ಡಿಸ್ಕೋಹೆಸಿವ್ ಫ್ಯಾಷನ್, ದಟ್ ಈಸ್ ನೋ ಕೋಹೆಷನ್ ಬಿಟ್ವೀನ್ ಸೆಲ್ಸ್, ಕೋಆರ್ಡಿನೇಷನ್ ಇರಲ್ಲ ಸೆಲ್ಸ್ ಮಧ್ಯೆ, ಅಂಟ್ಕೊಂಡಿರಲ್ಲ ಸೆಲ್ಸು, ಇಲ್ಲೊಂದು ಸೆಲ್ ಅಲ್ಲೊಂದು ಸೆಲ್ ಎಲ್ಲೋ ಈ ಥರ ಇರುತ್ತೆ. ಓಕೆ, ಆ್ಯಂಡ್ ಯೂಶಲಿ ಇನ್ಸಿಡೆಂಟಲ್ ಬಯೋಪ್ಸಿ ಫೈಂಡಿಂಗು, ಏನಕ್ಕೆ ಯಾವುದೋ ಒಂದು ರೀಸನಿಗೆ ಬಯೋಪ್ಸಿ ಮಾಡಿರ್ತೀವಿ, ಆವಾಗ ವಿ ವಿಲ್ ಬಿ ಡಯಾಗ್ನೋಸಿಂಗ್ ದಿಸ್. ಆ್ಯಂಡ್ ಯೂಶಲಿ ಇಟ್ ಈಸ್ ರೇರ್ಲಿ ಅಸೋಸಿಯೇಟೆಡ್ ವಿತ್ ಕ್ಯಾಲ್ಸಿಫಿಕೇಷನ್ಸ್ ಆರ್ ಸ್ಟ್ರೋಮಲ್. ಸೊ ಮ್ಯಾಮೋಗ್ರಫಿ ಮಾಡಿ ಅದರಲ್ಲಿ ಕ್ಯಾಲ್ಸಿಫಿಕೇಷನ್ ಇತ್ತು ಅಂದರೆ ಯೂಶಲಿ ದ್ಯಾಟ್ ವಿಲ್ ಬಿ ಡಕ್ಟಲ್ ಕಾರ್ಸಿನೋಮಾ, whereas stromal reactions, calcifications iವೆಲ್ಲ rarely seen in lobular carcinoma. So there is one more protein called E-cadherin which is known to maintain the cohesion between these cancer cells. Since there is E-cadherin mutation in case of lobular carcinoma in situ, there will be no cohesion and discohesive growth. So in MCQs they'll ask, how do you differentiate between ductal carcinoma in situ and lobular carcinoma in situ ಅಂತ, ಅಥವಾ ವಿಚ್ ಆಫ್ ದ ಫಾಲೋಯಿಂಗ್ ಟು ಕಾರ್ಸಿನೋಮಾ ಇನ್ ಸಿಟು ವಿಲ್ ಹ್ಯಾವ್ E-cadherin associated mutation. In that case, it is lobular carcinoma in situ. Okay, so on histology, how will be the findings in case of lobular carcinoma in situ? Cells are rounded due to E-cadherin mutation and lack of pressure by adjacent cells. So mucin will be present, and because of that reason, the cell nuclei will be pushed to surrounding, and entire thing will be covered with mucin. Okay, because of this reason it is called as signet ring appearance. It is appearing like a ring ಅಲ್ಲ, ಸೊ signet ring cells ಅಂತ ಕರೀತಾರೆ. ಕ್ಯಾಲ್ಸಿಫಿಕೇಶನ್ಸು ಇದೆಲ್ಲ ಆಬ್ಸೆಂಟ್ ಇರುತ್ತೆ. ಹೌ ವಿಲ್ ಬಿ ಡಯಾಗ್ನೋಸ್ ಅಂದರೆ ಬೇಸಿಕಲಿ ಮ್ಯಾಮೋಗ್ರಫಿಕ್ ಸ್ಕ್ರೀನಿಂಗ್ ಹೇಳ್ಬೋದು, ಆ್ಯಂಡ್ ಬೈಲ್ಯಾಟ್ರಲ್ ಪ್ರಾಲಿಫೆಕ್ಟಿವ್ ಮ್ಯಾಸ್ಟೆಕ್ಟಮಿ ಇಸ್ ಅ ಟ್ರೀಟ್ಮೆಂಟ್. ಓಕೆ, ಸೊ ದೆನ್ ಕಮಿಂಗ್ ಟು ಇನ್ವೇಸಿವ್ ಕಾರ್ಸಿನೋಮಾ. ಸೊ ಇಷ್ಟಕ್ಕೆ ನಿಲ್ಸೋಣ ಅಂತ ಅಂದ್ಕೊಳ್ತೀನಿ. ಇನ್ವೇಸಿವ್ ಕಾರ್ಸಿನೋಮಾ ಐ ಥಿಂಕ್ ವಿಲ್ ಕವರ್ ಇನ್ ನೆಕ್ಸ್ಟ್ ಕ್ಲಾಸ್.